Good afternoon. I'm very sorry that I cannot start with the welcoming address, Maori welcoming address, but it's my privilege to be on this land, and I'm grateful to organizers for an opportunity to address you. So, first, let me start with what I'm going to talk. In fact, in the World Health Organization, gambling has never been a priority and is still not a priority. And that's why, if just to speak about gambling, I think I will have very little to say. So that's why my presentation today will be organized around the similarities between substance use, gambling and gaming, and public health implications of these conditions. So first, I'll talk about a little bit about the epidemiology and impact on population health. Then I will talk about the gambling and gaming in the classification of diseases. And then we will talk about the public health dimensions of gambling, gaming, and substance use disorders, and a little bit at the end about the WHO activities in this area and about priorities for international research. So let's start with the substance use in the world. And we have the figures, and at the global level, it's a very important function of the World Health Organization to monitor the situation with major public health conditions. And we are monitoring the situations with psychoactive substance use. And we have these figures, which you can see that approximately 2 billion people consume alcoholic beverages in the world in the last 12 months. There is about 1.1 billion people who smoke tobacco products, and approximately 250 million who use psychoactive drugs other than tobacco and alcohol. If to speak about the gambling, so the global estimates and regional estimates simply do not exist. They are very different. There are different prevalence estimates in countries, and you can see that these figures. This is the figures about the prevalence of gambling. It's not about gambling disorder, it's prevalence of gambling. And what we know is that in studies which were conducted in different jurisdictions and different cultures, the prevalence of gambling during the last 12 months varies from 25% in Czech Republic to 80% in some Scandinavian countries, and in most countries where such studies were conducted, it's more than 50% of the general population. If to speak about the alcohol and drugs in the UN system, we monitor it not only at the global level, we monitor it at the global, regional, and country level. And we have the estimates of alcohol consumption or alcohol exposure at country level all over the world. For example, on this slide, you can see how the per capita alcohol consumption is distributed in the countries of each region, Africa, Americas, Europe, and you can see that in Europe it's the highest consumption in terms of alcohol. We know the estimates of alcohol use disorders and drug use disorders, and for alcohol use disorders our data is much better than for drug use disorders, and we have these estimates at the level of regions, global, and countries. And you can see that approximately 7% of men aged 15 plus and 1.3% of women suffer from alcohol use disorders. And the overall number of people in the world with alcohol use disorders is about 250 million. Whereas when it comes to drug use disorders, this figure is largely produced by United Nations Office on Drugs and Crime, as well as by academic institutions. And it's approximately 30 million people who suffer from drug use disorders, with injecting drug use around 12 million in the world, which is definitely important from public health perspective. We have the distribution of prevalence of alcohol use disorders by gender in different parts of the world, and we have the estimates for each country also disaggregated by gender and disaggregated in many cases by age. When it comes to prevalence of disorders due to addictive behaviors in the world, again, the estimates at the global and regional level simply are not available. And if you look at the data which are currently we have about the so-called problem gambling, and if you take past 12 months prevalence, it varies from, in the recent systematic review, which was published in 2016 by Collado and Griffiths, it varies from 0.1% to almost 6% in different samples. Some of them are national samples, which translates into from 3 to 350 million in the world. This range makes this estimate meaningless because it's too big by all means. And that's why we can say that these estimates attempts are made, but they don't exist, in fact. Also, what is important that in this systematic review, the studies were 69 studies which met the criteria for sound methodology, but from 30 countries, but only 3 from these 30 countries were from low and middle income countries. It's Brazil, China, and South Africa. So largely, we don't know what is the situation with addictive behaviors and with disorders due to addictive behaviors in most parts of the world, and our understanding of the phenomena and its scope is limited to a very limited number, largely high-income countries. Problem gaming. This is a relatively new phenomena introduced in 2013 as the internet gaming disorder in DSM-5 in classification of American Psychiatric Association. And if to use the criteria, most studies use the criteria from DSM-5. And past 12 months prevalence varies from 1.3 to 1.17% to 8.599%, which is a bit higher than similar estimates for past 12 months prevalence for gambling disorder. These are some data from prevalence data from countries where the studies were done, and this largely past year prevalence, though in some studies there are lifetime prevalence, and it can vary. So you see that the range is very significant, from 0.3% for past year to almost 5% for lifetime prevalence in South Africa, and approximately 3.55%, and this is past 12 months prevalence in the US. These are the prevalence studies on problem gaming, or again, internet gaming disorder, largely in general population on this slide, or in young adults, because very often these studies are done in adolescents, in convenience samples of students, or by telephone interviews of particular age groups, and they cannot be representative of the general population. So, and for gaming disorder, the prevalence rates are again in the range from 3.6 to 6%. What are the limitations of prevalence studies of problem gambling and gaming? First is sampling limitations. Many studies are non-representative convenience samples, often with narrow age limits and small sample sizes. There is a lack of international consensus regarding diagnostic criteria, both for gambling and for gambling is much better, but for gaming, it's a new phenomena, it's new condition when diagnostic criteria are yet not well defined. Use of different screening and diagnostic instruments and different thresholds of identifying the prevalence. And finally, is psychometric limitations of the instruments used, as well as cross-cultural limitations of the instruments. Most of them were developed in particular settings and then just transferred to other cultures and other countries, which normally the international instruments which are being used in cross-culturally, they need to be developed and tested cross-culturally as well at the stage of their development. Well, what is the impact on population health of these conditions? And this is the question that for us, from public health perspective, is of key importance. Well, we understand that there is phenomena exists. We understand that some people, and we saw the figures, have these health conditions. But what it doesn't matter, in fact, for health systems, for public health? Is it something of particular importance? How they rank in comparison to each other in terms of impact on population health? In the global public health, there is one matrix which is well established right now for measuring the different impact of risk factors or diseases on population's health. And this matrix was developed in the framework of global burden of disease study, and it's disability-adjusted life years lost. There are several, but this is the most often used. And one daily can be thought as one lost year of healthy life. And dailies is a combination of years lost due to premature mortality, to premature deaths, and years of life lost due to disability. For example, if a person with some disabling condition lives 20 years of this condition, so it will be calculated like 10 years of life if disability weight would be 0.5, for example. And overall dailies are calculated as years life lost due to mortality and years of life lost due to disability. If we look at the impact of alcohol, drugs, and we'll try to look at the impact of addictive behaviors on population health, we will see that definitely alcohol and harmful use of alcohol is the key, from all these conditions, is the key contributor to poor health globally, with WHO estimates coming up to 3.3 million deaths per year due to alcohol consumption, which in some other estimates is about 2.5 million in the world. But in any case, it's an enormous figure, which shows that from all psychoactive substances, alcohol is one of the biggest contributors to poor health globally. And 5% of the global burden of disease expressed in dailies is attributable to alcohol consumption. Why? We know that alcohol is toxic, teratogenic, cancerogenic, but at the same time psychoactive substance. And that's why then the range of conditions which are basic, when alcohol is contributing to premature deaths and disability is very big. If to speak about addictive behaviors, many of them would be not relevant because we are talking about behaviors. And only some domains would be relevant, would be similar between alcohol, drugs, and addictive behaviors. And what are these domains? These domains which are related to behavior. In alcohol, for example, is behavior influenced by intoxication. So it's under influence of alcohol. When you have injuries, and of course, neuropsychiatric disorders. So alcohol dependence or drug dependence. And in gambling and gaming is what we call gaming disorder and gambling disorder. If to look at, again, we have all distribution for alcohol with, by age, and these estimates are available at different levels. Also, this matrix allows to monitor the situation with population health during the years. These are the estimates done in the Seattle in the US by IHME, the institute. But what is interesting, published in 2017 in The Lancet. But what is interesting that with these graphs, with these tables, you see the trends, what is happening with the importance of different risk factors for health in 1990, 2006, and 2015. And these are comparable estimates. And you can see that, in fact, we have increase in the relative importance of drug use in the impact on population health worldwide. Whereas for alcohol is some increase, but it's much less prominent, and tobacco is also quite important here. Why? What stands behind that? What is the theoretical framework that allows us to look at these estimates? This morning, in the presentation of Professor Abbott, there was a discussion around adaptation and about exposure, the overall exposure theories, which can explain, from this theoretical model, you can explain dynamic with prevalence of gambling and pathological gambling in populations. For alcohol, for example, there is also a theoretical framework that allows to understand what are the factors which influence the impact of alcohol on population health. And there are many of them. Societal vulnerability factors, which can be what we heard also in the morning about communities, which have particular vulnerabilities to some issues like alcohol exposure or EGM exposure. And we have the individual vulnerability factors which define the individual risk of developing some conditions related to, in this case, alcohol exposure. And of course, sometimes these societal vulnerability factors are so powerful that they can override the trends in exposure. Like in some jurisdictions now, we see that for young people, it's not anymore popular or not anymore trendy to drink alcohol. There are different values now are important for young people. And that may explain, even if you have the same level of exposure, availability of alcohol, you can have very different figures in terms of prevalence of problems. Why? One important consideration, to do these estimates which I showed for alcohol and for drugs, you need to estimate so-called population attributable fractions. You need to have a list of conditions where this or that behavior or this or that consumption of this or that substance has a contributory role to deaths and disability due to these conditions. And this slide shows what are these population attributable fractions for alcohol. For example, alcohol use disorders, 100% are caused by alcohol exposure. But for example, in liver cirrhosis, it's 50% globally is caused by alcohol consumption. And you need this data to make the estimates for impact on population health. What if to speak about the disease burden attributable to gambling disorder? Global or regional estimates are not available whatsoever. Gambling attributable fractions for causes of death, disease, and injury and disability are not known. Australian and New Zealand studies indicate potential harm due to gambling comparable with the harm due to depression and alcohol use disorders. And, this study, this is what was mentioned in the morning in the presentations. But at the same time, if you look at the conceptual framework in dimensions of harm, many of them are the domains like emotional or psychosocial distress or financial harm, which can be very questionably attributed to the impact of gambling in this case on health, because it may be, it's of course well-being, it's social functioning, but if to speak about the disability and deaths, it's not really work very well. And that's why though these comparisons is very important to see what might be the perspective or potential impact of this condition on health, we need much more precise statistics which measures the impact on health specifically. It means death and disabilities. And there are some, of course, again, gambling behavior or gaming behavior has no implicit toxicity on tissues and organs. But we have some data from research which indicate that there is significant comorbidity between gambling, for example, and some disorders which have a very higher burden, documented burden, in the estimates of impact on population health. Comorbidity with mood disorders, up to 56%, anxiety disorders, alcohol use disorders, 73%, and drug use disorders, it's almost 40%. What is also important that in the same studies, which are big national studies using diagnostic instruments, gambling disorder precedes mood, anxiety, and alcohol use disorders in approximately 25% of cases. Suicidal deaths one of the most important public health problems in many countries, is the problem which attracts a lot of government attention. And we have some data which shows increased on suicidal ideation and prevalence rates of suicidal behavior in patients or in people with gambling disorder. And there is, in Hong Kong, for example, there are some studies which show that approximately 20% of suicides are associated with gambling disorder. Well, so what does it mean? So we don't have, what about gaming disorder? It's even worse. For gaming disorder, but it's really new. We don't have any data, and most probably we will not have any data in the nearest future in terms of impact on population health. And this, we will need a lot of case control longitudinal studies to come to establish the relative risks associated with gaming behavior, to measure risk factors to health, to measure health conditions, and particularly in children and adolescents. Well, let me talk about the classification of diseases, because the classification of diseases have important framing for how the condition is perceived in medical community, how it's being perceived by public health professionals, and how it's being perceived in communities, in societies. First, as you probably heard, in the World Health Organization, in the latest revision, in the 11th revision, which is going to be released this year, the gaming disorder will be introduced as a new diagnostic category. And we have a lot of questions around that. And we have a lot of criticism from some groups and a lot of support from other groups for this decision. And to justify this decision, or to explain why we did this move, it's important to understand what are the main objectives of international classification. One of the main objectives is to ensure systematic recording, analysis, and comparisons of statistical data which indicates what is happening in populations with health of people in terms of deaths due to different conditions, and in terms of treatment demand, and in terms of insurance and disability payments. Another important objective of classification is its clinical utility. Classification should be useful for clinicians, for health professionals. Classifications helps to identify particular conditions in patients when they come to visit health professionals. And clinical utility incorporates also the guidance that classifications provide in terms of selection of prevention and treatment interventions in every case. At last, the classifications should facilitate international dialogue, cooperation, communication, and international research, as well as education and training of health professionals. We found that currently we have all sufficient evidence and data to say that inclusion of gaming disorder in ICD-11 would meet all these requirements and will have, and it now has clinical and public health utility. If to speak about one of the criticisms that sometimes we hear is that diagnostic criteria are not yet well established for gaming disorder, which may make it premature to include this diagnostic category into the classification. I just want to remind you that first international classification was, though international means doctors from 6 countries participated in development of this classification, which had 140 categories. But in this classification, there was already alcoholism and delirium tremens. 150 years before even the concept of diagnostic validity or diagnostic criteria was established in medicine. At the same time, Hippocrates described melancholia thousands of years ago. And still, this equivalent of depression continues to be used by health professionals throughout the centuries. So now we had the last classification, ICD-10, was in 1993, though it was finished in 1991, in fact, but it was largely implemented in 1993. Now we have the 11th revision. Those who work in psychology, clinical psychology and psychiatry, they know that there are the two major classifications of mental behavioral disorders. One is ICD, International Classification of Diseases. Another one is Diagnostic and Statistical Manual of American Psychiatric Association. Major difference is that the ICD is the system which covers all conditions, cancers, respiratory diseases, everything. DSM, it covers only mental behavioral disorders. For ICD, what is important is monitoring not only health conditions, but also mortality, causes of death. It's very important. DSM is largely concerned with mental and behavioral disorders in clinical practice. DSM is owned by American Psychiatric Association. Selling of DSM is one of the major income sources, and ICD is owned by member states, by WHO member states, so it's being used around the world. What is the evolution in classifications? Their importance is also what terms are being used in the classification, because this nomenclature, so-called, defines significantly how people relate, or what are the perceptions or attitudes towards the conditions which are described in classification. And just as an example, sometime now we are talking about addictions, right? And the DSM-5 introduced the addictions and promoted very much the term of addiction. Whereas in ICD, in 1955, we had a drug addiction, for example, the term alcoholism and drug addiction. There was alcohol addiction in ICD-8 in 1965. But then in 63, 64, our expert committee on drug dependence decided that addiction is stigmatizing term. And that's why we need to move away from this term and to use the term dependence. And since that time, we use dependence. And up to now, in ICD-11, we will use dependence syndrome as the main diagnostic category for substance use disorders. In fact, first time, the concept, the diagnostic category of pathological gaming was introduced not in DSM-3. It was introduced in ICD-9 in 1975, 5 years before it appeared in the classification of American Psychiatric Association, as pathological gambling in the section of disorders of impulse control not elsewhere classified. In DSM, 5 years later, it's appeared in DSM-3 with in the same section, in the same group. In ICD-10, sometime after, the pathological gambling appeared in the same, but in habit and impulse disorders. That's what they call this section. Together with pathological fire setting, stealing, trichotillomania, and at the same time, in DSM-4 TR, there was some revision of diagnostic criteria for gambling, for pathological gambling. In 2013, new classification of American Psychiatric Association, DSM-5, was published. And now we are going to release this year International Classification of Diseases, 11th revision. And you can see that in both cases, pathological gaming renamed. It now gambling disorder in both classifications. What is very important for today's conversation, for today's talk, is that gambling disorder was reclassified in DSM-5 from the section of impulse control disorders. It was conceptually integrated with the section of substance use disorders, which have very significant implications. And we fully agree with colleagues with the working group of American Psychiatric Association that this condition should be in the section which describes disorders due to substance use. So that's why in ICD-11, it's in the same group. In the section of chapter 6 where these conditions are is called disorders due to substance use and addictive behaviors. And we introduced the word addictive here, though we avoided this term for many years, because otherwise you can't incorporate behavioral addictions into the classification not using this expression. In DSM-5, there was elimination of illegal acts criteria and a little bit lower diagnostical threshold. Instead of 5 from 10, it's 4 from 9. Diagnostic criteria needs to be present for making a diagnosis. In ICD-11, in gambling disorder, as well as in gaming disorder, we have two subtypes, predominantly online and predominantly offline. Why this major change, the move from of gambling disorder from impulse control disorders to substance use disorders took place? For several reasons. And I think it's very difficult, though some scholars argue, they think that it's premature, that there are much more differences than similarities between substance use disorders and gambling disorder. But overall, we have several domains of similarities. One of them is neurobiological commonalities, which are demonstrated by imaging studies, by neurochemical studies, which show that they are very similar. In fact, also how reward system works, how the dependence develops, very similar to substance use disorders. Comorbidity profiles, very similar. And in fact, as we saw before, that gambling disorder is, in most cases, is associated with alcohol use disorder and insignificant, up to 40%, with drug use disorders. The clinical manifestations and natural cause of these conditions are very similar. It's not necessarily chronic condition. There is a spontaneous recovery in significant number of cases. The cognitive mechanisms were described, which show similarities between these conditions. And treatment approaches are very similar. In fact, we have self-help groups, we have community actions, but what is also that is not on this slide is prevention activities, and prevention strategies are very similar. And we will look at these preventive strategies a bit later. So how the disorders due to addictive behaviors described in ICD-11? They are described as recognizable and clinically significant syndromes associated with distress or interference with personal functions that develop as a result of repetitive rewarding behaviors other than the use of dependence-producing substances. And in ICD-11, and this is a big difference with DSM-5, when internet gaming disorder was included not in the main part of classification, but in the section for further research. In ICD-11, we think that we have sufficient, because American colleagues did it in 2012. They made all decisions. We made decisions in 2016, and we found that we have sufficient in this period of time. There is sufficient evidence to include the gaming disorder in ICD-11. This is how the ICD-11 section looks at the moment. So they are very similar, gambling and gaming disorder, with the same two subtypes, predominantly online and offline. And we have other specified disorders due to addictive behaviors, which is a place when, if in any jurisdiction there are other behavioral addictions are recognized and people are coming for treatment, this gives an opportunity to code these conditions in this category. At the same time, in WHO, we don't want to send any message that we recognize other conditions, like, for example, sexual addiction or jogging addiction or smartphone addiction or internet addiction, because we carefully examined all these conditions. And we found that there is no sufficient evidence at the moment to speak about these conditions as separate diagnostic entities. This is a definition of gambling disorder. It's simplified, and it's again, it's even more closer to substance use disorder, how it appears now in the draft ICD-11. Basically, it has three main essential features: impaired control, or I would say rather impaired regulation of gambling behavior. It's increasing priority given to gambling to the extent that it takes precedence over other life activities and daily activities, and continuation or escalation of gambling despite the occurrence of negative consequences. But it's not enough for a diagnosis. It's three essential features, but you can't make a diagnosis with even if these three features are present. The same, by the way, for gaming. What you need is that this severity of these features should be such that it interferes, it results in significant impairment in personal functioning, and this impairment, the evidence of this impairment is documented for at least 12 months in most cases. And only then a trained health professional might make a diagnosis if these criteria are fulfilled. At the same time, we make clear that if full-blown symptoms persist for less time, you still can make a diagnosis. What is also important to mention that in ICD-11, and in general in ICD system, we have a special section which is talking about risk factors which influence health status. Why this special section is important? Because it provides opportunities for preventive interventions. And when you have a code in the system, it allows health professionals to deliver interventions and in most cases to be reimbursed for, if, depending on the system, for these interventions, if there is a code. In ICD there is, and it was in fact in the past, the hazardous gambling or betting and hazardous substance use. These were the categories which existed in ICD-10 and in some way existed in ICD-11. But what is added is hazardous gaming. However, this is a definition of hazardous gambling, and in this audience there is a person who contributed significantly to this definition, and I mean Professor Robin Room, who worked with us on developing this definition. But what is it about? It's about the behavior which does not result to harm to health, but it's associated with significant increase in risk for negative health outcomes. But we have one unsolved problem, and I can tell you what is this problem. This is a taxonomy of disorders due to substance use and addictive behaviors, which we currently have. I want to remind you that Professor Abbott in his presentation this morning shown the results of estimation of harm due to gambling based on Australian and New Zealand studies by Matthew Brown. And he showed that almost 50%, so-called prevention paradox, that 50% of harm is associated with, not with gambling disorder, but with low and moderate risk of gambling behavior. What, if to translate it into the language of substance use disorders, would be harmful use of substances and not substance dependence. So, if we look at in disorders due to addictive behaviors, then we have gambling disorder, gaming disorder, we have hazardous in another section, but we don't have harmful addictive behaviors. And because there is no studies, we cannot introduce this because it's almost nothing in the literature regarding these conditions. Though, theoretically, it should be there because it opens up a possibility for prevention interventions. And it would be very much in line with our understanding of the spectrum of disorders due to substance use and addictive behaviors, which will be very important for prevention interventions, for example, for introduction of brief interventions for early stages of gambling or gaming behavior, when you can interfere and when you can prevent development of a disorder. But the scientific evidence, the data that we have, is simply insufficient. Now we are doing field testing of ICD-11, and we hope that as a result of field testing, we will have a strong call for introduction of this diagnostic category in the classification. This is what this Brown studies, which was already discussed. Well, what about public health dimensions, leaving aside epidemiology and everything? Why gambling and gaming is now on the public health agenda, and why it became an issue for the World Health Organization in recent time. Though before, it was never considered by our governing bodies. Our ministers of health, when every year they come to Geneva in May each year to discuss agenda of international work on health, they never considered gambling disorder or pathological gambling. And of course, they never considered gaming. It's very, very new. But they considered, and not once, drug use and alcohol and impact on health. Why? First, because we have increasing availability of gambling and gaming platforms and products. And if this availability is particularly important from public health perspective in deprived communities, in different segments of the population, due to economic reasons and digital online opportunities. And these digital opportunities provide, again, we don't have data from less resourced countries, but you can imagine that digital marketing and digital opportunities provide unrestricted access to online gambling and gambling in any part of the world, be it a very poor community somewhere in an African country or in Asia or elsewhere. It's easy now. Second is we have better understanding of health and social consequences of excessive gambling or gaming. Basically, though it's definitely not sufficient, as I tried to show, that we don't have good metrics of impact of these conditions on population health. This is reflected also in increasing treatment demand for gambling and gaming disorder in many countries. For example, in Geneva, in Switzerland, where I'm coming from, in almost half of patients in treatment services for substance use disorders are with behavioral addictions, and not anymore with heroin or with cannabis or with anything else. Its convergence is limited, its convergence of gambling and gaming platforms, networks, and products, and that was mentioned already this morning. Its technological sophistication and increasing use of the internet-based technologies, which present new challenges for public health. And, again, its conceptual integration with substance use disorders, which shift a little bit how we look at the prevention strategies for these conditions and make to think us more about what approaches worked for alcohol, what approaches work for drugs, and will similar approaches be effective when we are talking about addictive behaviors. Not by coincidence that very recently in two very influential journals, scientific journals, Nature and The Lancet Medical Journal, there were two editorials which show the following. Nature is in January this year. Researchers and government agencies pay too little attention to pathological gambling. This must change. This is a very significant call from one of the most influential scientific journals in the world. Lancet, one of the most influential medical journals. Problem gambling is a public health concern. One of the reasons of this increased attention is new opportunities which provide digital platforms and digital products. And again, we discussed already, it was mentioned, that now we see convergence of gambling and gaming. In gambling products, there are many elements of gaming to make it more attractive. In gaming, there are many elements of gambling, which are famous loot boxes, which here you can see the games, and very popular games, which have the elements of loot boxes when you buy for some virtual objects, which can, in fact, substitute your skills. You can get upper in the game if you just put some money into that. And when kids have access to credit cards of their parents, parents might have very unpleasant surprises when they come back after some time being away. So, and this is how it looks, these loot boxes, when you can pay and get something from this box. And gacha system in Japan, which is also monetization of gaming with money. And we have case study recently in one of the meetings that we organized specifically to look at the validity of gaming disorders diagnostic category. We have case studies presented from 19 countries, from America, Europe, Asia, all different, India, China. So clinical case studies of disorders due to gaming behavior. And one of them is, one of the cases was when, in fact, it was a young adult who made a debt which was equal for family income for 1 year, just because of these issues. The question is, what is the impact on health again? Again, its financial losses is important. We know that it causes depression, it causes the family dysfunction, etc. But to be strongly on health grounds, we need good evidence of impact on health, on particular conditions. Also, another issue that for all of us are of significant importance, social networks. This is something which young people are in. This is what is part of their life, and they will never abandon this part of life. 56% of games on Facebook have gambling elements, and these games tend to be owned by gambling operators. We need to speak about the policy frameworks. And now, again, I will try to make parallels between different psychoactive substances and addictive behaviors. For psychoactive substances, we have strong frameworks. We have conventions, which are legally binding conventions for psychotropic substances and narcotic drugs. We have framework convention on tobacco control, which is also legally binding document. And we have non-binding global strategy to reduce the harmful use of alcohol, which was negotiated for more than 5 years and at last was endorsed by the World Health Assembly in 2010. When to ask what are public health implications of gaming? So what is it about? What is public health aspects? What are public health dimensions? We had this question from member states recently when it comes to drugs. And we identified in the Secretariat these elements: prevention, reduction of vulnerability, treatment and care of people with these disorders, prevention and management of harms, so harm reduction strategies. This is not relevant for gaming disorder, and monitoring and evaluation. So we can say that the same elements, in fact, constitute the public health dimensions of addictive behaviors. When the global strategy defines what should be done, and it defines on alcohol, it should address levels of alcohol consumption, patterns of consumption, context, and wider social determinants of health to be effective. And special attention should be given to reducing harm to people other than the drinker, so-called harm to others concept, which was very instrumental in developing tobacco regulations. This is the list of strategies or policy domains which are important to address to reduce the harmful use of alcohol. And it involves 10 very specific areas. But what from them, what are they effective and what don't produce the results? And again, I want to emphasize, in terms of results, we need good metrics. It's not sufficient to have a perception that it works, it's nice, it's well accepted. We need to document that, in fact, implementation of these strategies reduce the negative impact of these substances on population health. In WHO, we recently, based on cost-effectiveness studies done in different countries, we finished the exercise with what are the most cost-effective interventions for reducing the alcohol harm, alcohol-related harm. And unfortunately, the most cost-effective interventions are less popular because they are regulatory measures. Taxation and pricing policies on alcoholic beverages. Bans or restrictions on exposure to alcohol advertising and marketing restrictions. Restrictions on the availability of retailed alcohol. And then, with also cost-effective, but with much less cost-effectiveness, are drink driving laws and brief psychosocial interventions. It shows also some other measures which are important, including those which are consumer information about the harms, prevention, treatment, and care for comorbid conditions, substance use disorders. It's all important, it's all necessary, and that's why we list them. But if to speak about the most cost-effective interventions, when you have little resources and you want to achieve bigger impact, here they are. In Sustainable Development Goals 2030, there is spatial target. And this is a very important framework for the UN system and for governments, is strengthening the prevention and treatment of substance abuse. Unfortunately, addictive behaviors is not part of that. And in fact, addictive behaviors not anymore under mental health, strictly speaking. So they are falling somewhere in the middle, which of course is a challenge. What are the policy options which are being studied and which are being discussed for prevention of behavioral addictions? Limiting availability and access, very similar to what we saw for alcohol. Reducing risks and harms, and these are information awareness campaigns, including on-site information and counseling, self-exclusion programs, setting gambling and gaming limits, warning messages, training of venue employees, providing health services. But this is what very seldom discussed, in fact. It's very often not at all on the agenda of discussion, of discourse about policy measures. Is potential pricing, regulations, and advertisement and marketing restrictions. This is, again, the illustration from different countries. What are examples of prevention policies and strategies for gaming disorder? And what you can see here, then when it comes to legislation and enforcement, in most countries, there is none. When it comes to early targeted prevention, in public services, in public sector, there is none in many countries. At the same time, there are many things which are related to education, awareness, guidelines, but we know that the impact of these measures, it's important to do that, but you are not achieving significant reduction in the harm due to these conditions. Of course, there is a big issue of economic interests. And you always need to balance when it comes to conditions when economic interests play an important role about the revenues, about the benefits, economic benefits, and about the protection of public health. And in global strategy, for example, we have a mandate to talk to alcohol producers, and we do it regularly. But we are talking with them about what they can do in terms of reducing harmful use of alcohol as producers and distributors of alcoholic beverages. But we are not discussing with them what policy measures are effective, because the conflict of interest with this sector is too high, too big to talk about policy measures with alcohol producers. In WHO, we have spatial framework for interaction with non-state actors, which defines how we need to deal with conflict of interest. And the last part of my talk, what we are actually doing in addictive behaviors. We had 4 technical meetings. Largely, these meetings were exploring the public health impact of addictive behaviors with focus on gaming, But later on, we addressed all the issues which were necessary for us to consider to include or not gaming disorder in ICD-11. And in the forum, this last year, we had the first forum in WHO on alcohol, drugs, and addictive behaviors. So addictive behaviors is firmly established as the third track of our work on conditions which are related to substance use. And this forum was attended by civil servants from countries, by mission representatives, diplomats, by academics, and by civil society representatives. Well, what are priorities of international research in this area? They were, due to these meetings, we identified several of them. First, information of prevalence, risk factors, and incidence rates of conditions. Still, we have very little data. Public health implications of monetization of gaming and esports. Undertaking in-depth qualitative studies about lived experiences. I'm very pleased to see that one of the sessions in this conference would be on that. Exploring validity and public health utility of diagnostic categories. Scientific basis for guidance on healthy patterns of digital technology usage. Developed international screening instruments for gambling and gaming, and we are working on that right now. And implementation and evaluation research and prevention strategies and policy options. We need validated, empirically validated effective policy options and evaluation of effectiveness of treatment options. Conclusions. First of all, there is an increasing and well-justified concern around public health implications of addictive behaviors. And in view of rapid developments in technologies, it becomes even more pressing. Data on prevalence of addictive behaviors and associated disorders is very patchy and does not allow to produce reliable global or regional estimates. Impact of addictive behaviors on population health is still poorly documented. Conceptual integration of disorders due to addictive behaviors with substance use disorders provide new opportunities for development, prevention, and treatment strategies and interventions. And massive international research efforts are needed to inform policy and program development in this area. And thank you very much for your attention.
Thank you very much. I think people will have found that very interesting to get a sense of the World Health Organization and how it functions and where gambling and more recently gaming disorder and related harm fit in. And I think it's very timely in terms of developments at WHO that there is this opening and this focus for the first time on the behavioural addictions alongside alcohol and drugs. You know, for the first time, they've actually come together and been looked at in an international forum. So I think we've got a little bit of time over for questions, just a couple of questions. One question, then maybe, yeah, okay. Somebody particularly want to ask a question? Well, we have two? One?
Just one.
Oh. Okay.
Given that you've alluded to the fact that gambling is now a second and third world issue, not just the first world issue, and I'm wondering how much does that reality impact on the ministers to which the World Health Organization relates?
As I said, there was no discussion whatsoever of these conditions. At the same time, starting around Christmas last year, there was a massive representation of this information in major mass media sources. In all parts of the world, major newspapers and journals wrote about inclusion of gaming disorder in ICD-11. We expect that that would be prominent on the radar of the governments. At the same time, as always, you need some governments which will take it forward at the meetings of governing bodies of the World Health Organization, but it's entirely in the hands of the governments of member states. We in the Secretariat are serving member states, and they provide guidance on prioritization of health issues in the organization.
Yeah, that's a very important just like to briefly comment. Our new Associate Minister of Health, the Honourable Jenny Salisa, who covers mental health, addictions and gambling, I had a meeting. She apologises for not being here to open it, but there was a cabinet meeting and the ministers were expected to be there. But I did discuss a number of issues with her. I met her and was very generous of her, actually, because I saw her on Friday evening for about an hour and a half. We covered a range of issues, but gambling was certainly an important area. And I discussed with her this issue of the importance of governmental support to get issues on the WHO agenda. And she said, what other countries do you think might join us? So, you know, there's a long way to go, but I think there is an opening there now, and we may be able to move this really important, because getting it on the WHO agenda gives huge legitimacy, and particularly to those parts of the world where this is not an issue that's taken seriously.
Well, thank you very much. We'd just like to present Dr. Vladimir with a thank you gift.
Yes, okay. Thanks very much.
Thank you very much.